6, 5, 4, 3, 2, 1. Here we go.
Well, welcome one and all for our very new episode number 8 of this ever so entertaining Rising Stars in Ophthalmology. Well, I'd like to inform all the viewers that we've crossed 2,500 people in the Rising Stars family, and it crosses through all generations, geographies, especially reaching to those who actually can't make it to these big meetings. And can't thank our faculty more than anything right now. Also, please follow us on our social media handles on Rising Eye Stars, Facebook and YouTube on Rising Eye Stars in Ophthalmology page. For the folks who weren't with us until the last time, Rising Stars in Ophthalmology Season 1 is a 9-episode interactive series that will focus on bringing all of us new innovative technology from the speakers that, according to me, are the finest surgeons, orators in the new world of ophthalmology as we see it. The program's being aired on our website, Rising Eye Stars, and on Facebook and YouTube. But we love questions. We love questions because they kind of they bring out a lot of innovative thoughts and newness to the whole field of ophthalmology as we know it. All these episodes are available on our website after the event, because this is a global event and the timing sometimes may not suit the rest of the world. So if you want to see what is old is gold, please go to the risingeyestars.com website to view them. As for today's episode, we have an absolutely fabulous celebrity panel list and a speaker who's done exceptionally well in the field of ophthalmology. I'd love to introduce my co-moderator, Jennifer Lowe, who's been nothing but exceptional supporting me through this whole process, along with Bill Trattler, whose smile just takes over the screen as soon as you see it. But and I would love to introduce Jennifer Lowe to introduce the special talk as well as the celebrity panelists and speakers. Jen, all yours.
Thank you so much, Ashwin. As always, it's such a pleasure to be part of your program. I apologize for my lack of the proper background, but I'm actually celebrating an early St. Patrick's Day tonight, so I wanted to showcase on green screen. So first, before we get started, I'd like to actually thank all of our sponsors for the Season 1, without which it would be difficult to run such a successful program. So thank you again to Allergan, Centricity Vision, BVI, Elisar, Zeiss, Sustain Ilux, Alcon, Biotissue, Tarsus, and Sun. And for the next few minutes, I'll be introducing Dr. Liz Yu as well, who will be speaking to us on Tarsus.
Hi, good evening. My name is Elizabeth Yu, and thank you so much to the Rising Stars program for allowing us to present tonight. I will be presenting on behalf of Tarsus. So a little bit of a background. Tarsus has a lead medication asset that would be the first potential FDA-approved treatment for Demodex blepharitis, which is truly a very large, underserved and market for such a ubiquitous disease process. While this may be a little bit of a busy slide, I hope that you're able to appreciate a lot of the different details with regard to the background of Demodex blepharitis, as well as the potential benefits of using TP-03, which is that molecule with lotilaner 0.25% ophthalmic solution on the right side of the screen. But essentially, with regards to Demodex blepharitis, extremely prevalent, between anywhere from 9 to 25 million Demodex blepharitis patients. And depending on the literature and the understanding of incidence, this can be dissected in various ways. But truly, it is certainly an underdiagnosed ICD-9 code, simply because there truly hasn't been any RX therapeutic that has been yet available to date. But Demodex has many implications from the blepharitis side, with itching, foreign body sensation, all the way spanning to more severe sequelae, including scarring, as well as manifestations onto the corneal surface. But there are buckets of patients that we can certainly see that this has its potential implications with. There's certainly a large proportion of our cataract surgery patient populations, which fits right into the higher risk factor, which is an older aged population with Demodex blepharitis. There is a significant overlap with dry eye disease, and they truly are comorbid conditions, with 69% of dry eye patients having Demodex blepharitis in a recent study by Anat Galor, versus 80% of Demodex patients having dry eye symptomatology. And of course, our concerns there as it regards to contact lens discontinuation. TP-03, or lotilaner, is a non-competitive antagonist of insect and arachnid invertebrate GABA chloride channels. So it causes paralysis, and in ex vivo studies, it demonstrates that with this specific concentration, Demodex mites are killed within 24 hours. Tarsus is currently undergoing its FDA pivotal trial, the phase 2b/3a Saturn I study. And on the right here are some photographs of patients who have Demodex blepharitis, which with lash lines significant of collarettes, which are cylindrical dandruff that are encuffing at the base of the lash, and then what the lash line looks like post 28-day treatment with TP-03, a much quieter lash line and a healthier looking lid. Collarettes can easily be missed on examination when patients are looking straight ahead, because these collarettes, which are those very tight debris, translucent, almost waxy-like, that are encuffing the lash base, if they're looking straight ahead at a cross-sectional view, it can certainly easily be missed, especially with lid abnormalities that may be present, such as dermatochalasis. But the same patient looking down, you can certainly appreciate the significant amount of collarettes or Demodex blepharitis that we can see here. So the corporate highlights, just to quickly go over with regards to Tarsus. With regards to Saturn I trial is undergoing and has been enrolling since September 2020. Saturn II will begin initiation, which is another second phase 3 study right on the heels of Saturn I. And then the pipeline with this active ingredient and asset, it can be potentially helpful in MGD, as Demodex also mechanically obstructs the meibomian glands, with rosacea, as type 2 rosacea or papulopustular rosacea is due to Demodex blepharitis, and the potential in the prevention of Lyme disease and malaria spread. So in conclusion, this is the introduction to Tarsus and the first potential benefits with a potential therapeutic in the realm of eradicating.
Okay, well, thank you so much, Dr. Yu, for a great presentation on a novel and new product. I'd like to change gears, and I'm actually going to share my slides here in order to introduce our celebrity panelists and our speaker. So again, tonight, welcome to episode 8 of season 1, entitled Journey to J1+, Advances in Lens-Based Solutions for Presbyopia. I'd like to first introduce Dr. Priya Gupta. She's an associate professor of ophthalmology and the cornea, cataract, and refractive surgeon at the Duke University Eye Center. A little known fun fact is that she was actually a star golfer in high school. So thank you, Dr. Gupta, for participating tonight with your expertise. We also have Dr. Eric Donnenfeld, who is a cornea, cataract, and refractive surgeon at the Ophthalmic Consultants of Long Island. He's also on the board of directors for Spectrum Vision Partners and a trustee of Dartmouth Medical School. And he was also former president of ASCRS. And his fun fact is that he participated in both the basketball and crew teams at Dartmouth. So we have a very athletic celebrity panelist tonight. Now, last but not least, we have Dr. George Waring IV. He's the medical director at the Waring Vision Institute in South Carolina, and he also is an athlete tonight. He was a competitor in the National Freestyle Whitewater Kayak Tour in 1998. So in addition to learning about ophthalmology tonight, we'll be picking the brains of our superstar athletes. I'd like to also introduce our rising star tonight, Dr. Dagny Zhu. Thank you so much, Dr. Zhu, for participating. As you can see from her list of achievements and her medical school at Harvard, UCLA, undergrad, residency at the Doheny Eye Institute, and fellowship at Bascom Palmer, she is superbly well trained. She is not only an ophthalmologist, but she's actually the medical director and owner of a high volume LASIK cataract and refractive center in California. And she's also on staff as an attending for a residency program, as well as a clinical preceptorship for a medical school. Her area of focus is she's a refractive cataract surgeon, and she does a very high volume of premium IOLs, laser vision correction. She helps treat keratoconus, pterygia, and corneal transplantation. And last but not least, in 2020, she became a first-time mom, and here you can see a beautiful picture of her baby and her. All right, Dr. Zhu, thank you so much for participating in our series tonight. I'll let you take the lead next. Oh, and so sorry, last but not least is a wonderful picture too of her husband and her child. And she's very active on social media. So thank you. And I will stop sharing my screen now. So sorry about this. I don't know what happened to my thing.
All right, I will share
Okay,
mine.
Dr. Zhu, you take over. Thank you.
Oh, thank you so much for that wonderful introduction. I just want to thank everyone here. It's just to present to such a distinguished panel. So thank you so much for the opportunity. So tonight I'll be talking about Journey to J1+, Advances in Lens-Based Solutions to Presbyopia. I am a consultant for Alcon, which is a manufacturer of some of the technologies I'll be discussing tonight. So presbyopia correcting IOLs have come a long way. It all started back in 1997 with the Array, which was the first multifocal IOL to be approved in the US. And then this was followed by a boom of technology in the 2000s with different technologies such as accommodative lens and diffractive multifocals, which are still mostly on the market today. And then the next innovation didn't really come until I was a fellow at Bascom Palmer in 2016. The Symphony was approved as the first extended depth of focus lens, and it offered a more continuous extended range of vision. And then most recently, we're very lucky to have these two great innovations. In 2019, we finally got our first trifocal lens approved in the US, which was the PanOptix, and more recently the Vivity in 2020, which is the first of its kind non-diffractive extended depth of focus lens. And so when we look at the presbyopia correcting lenses we have today, we can basically divide them into two groups, those that are non-diffractive and those that are diffractive. And of course, there's a big difference between the two. We are all familiar with the diffractive lenses, which have the concentric rings, and they probably provide the fullest range of vision, but of course, with some compromise in visual quality. And so there's always still a place for our non-diffractive presbyopia correcting IOLs, which provides perhaps less near, but preserves fairly good quality of vision. And so I'll just discuss a little bit about the two most recent innovations. I won't go into too much detail, but the PanOptix, again, was the first trifocal IOL to be approved and the only one still in the US. And because of its larger 4.5 millimeter diffractive zone, it's able to provide 3 focal points, distance, intermediate, and near. And the central zone light distribution is focused on intermediate. Overall, it is designed to be less pupil dependent and less dependent on lighting conditions. And it actually increases the total light utilization compared to some of the previous generation multifocal models with 88% total light utilization at a 3 millimeter pupil size. So overall, it preserves the contrast and quality of vision fairly well at all 3 focal points. And as some of you may know, again, the focal points are at distance, intermediate, which is set at about 60 centimeters, which is the most comfortable sort of distance of where we have our arms relaxed. And in this digital age, it's where most people hold their laptops or iPads. And then it also has the near point at 40 centimeters. Of course, we know that the PanOptix trifocal is great in that it provides a much fuller range of vision than what we were used to with the bifocal lenses. But of course, it still has the same dysphotopsias and decreased contrast sensitivity issues that are similar to other diffractive technologies. And then most recently, the Vivity just launched nationally earlier this year. And again, it's the first and only of its kind non-diffractive extended depth of focus IOL. And basically, without getting into too much detail, it's able to provide a more continuous extended range of vision by stretching and shifting light instead of splitting it. And I know a lot of people are skeptical on how it works without using diffractive technology, but essentially the way that the wavefront travels through the center, it is delayed and focuses closer in front of the retina, which provides that functional near vision. And the wavefront that passes through the periphery of the lens, it is advanced and passes quicker. And so focuses further back, closer to the retina, providing that distance vision. And so as this wavefront propagates, it continues to collapse and is essentially stretched forward and backward, providing that continuous extended range of vision. And it does so from distance to intermediate up to a functional near, which is about J3. And because it's not diffractive, it's not splitting light, the FDA trials have shown that it has a visual disturbance profile similar to a monofocal with minimal dysphotopsias and overall pretty good contrast sensitivity. And of course, it doesn't provide as much near. It's not going to give you that J1 plus that you can get a lot of times with the traditional bifocal lenses, as well as the trifocal lens. And not every lens can be classified as an EDOF lens. The Vivity is actually only the second one to receive this title. And that's because it has to fulfill a number of specific criteria. Namely, it must provide a greater depth of focus of about 0.5 diopters greater than the monofocal control, giving a visual acuity of about 20/32. The distance corrected intermediate vision has to be not only superior to monofocal, but more than half of patients have to achieve a distance corrected intermediate vision of 20/32 or better. And of course, the best corrected distance vision can't be inferior to the monofocal. And so the Vivity lens fulfills all this criteria. And with the naked eye, it looks just like a monofocal lens, but you see here under the magnification of an operating microscope, you can see that central 2.2 millimeters where all that action of the stretching and shifting of light is happening. And so today we have much more expanded IOL options to offer our patients. And so we're able to offer presbyopia correcting technologies to more patients than ever before. But of course, you can see there's going to be a wide range of offerings that each lens can provide. For example, the further right that we move, we can offer greater spectacle independence, but at the same time, we are sacrificing a little bit of that quality of vision. And so with our patients who have higher than ever expectations today, their desires may not necessarily match their exam findings and what they qualify for, and their expectations sometimes are a little bit unrealistic and they don't understand the limitations of technology. So it's really up to the surgeon to match each patient to the best presbyopia correcting IOL for them. And you do that based on the patient's visual needs as well as their exam findings. And in terms of assessing visual needs, I like to ask all my patients 4 essential questions. Of course, all patients want everything. They want the fullest range of vision possible, but usually they value one more than the other. And one thing that helps me identify that also is asking what occupation and what they do for a living, because that not only lets me know what distance they might value more, which is going to differ obviously significantly between a pilot, jeweler, and accountant, but it'll also let me know how tolerant they are of perhaps a little bit of blur and how willing they might be to sacrifice a little bit in their quality of vision. I ask all my patients how often they drive at night because, again, dysphotopsias remain an issue for diffractive lenses. And so I like to know how often they might encounter that situation. And finally, one question that perhaps not too many people think about is I like to know how patients are currently seeing, because again, it lets me know how flexible they are and how tolerant to a little bit of blur they might be, because someone who never wears glasses might be a lot more tolerant than perhaps someone who wears progressives 24/7. And so all of that helps me decide which IOL is the best. In terms of the exam findings to help me match which IOL is best, in addition to the careful refraction, slit lamp, and dilated fundus exam, I like to carefully assess the tear film. I get a topography on every patient. I also get a spectral microscopy on every patient just to assess the health of the corneal endothelium, because sometimes mild guttata can be missed. And I do also get an OCT macula and OCT RNFL, sometimes visual fields, just to make sure I'm not missing any mild pathology. And so that's enough for me. I really want to just hear from our lovely celebrity panelists and cases that I've encountered in my own practice. And for these patients, a lot of the times what we're trying to decide is to diffract or not to diffract. That is the question. I was on a panel with Dr. Ike Ahmed last week, and he was saying that he approached every potential patient who comes into his clinic as a trifocal candidate, because we assume that every patient is looking for that fullest range of vision, but of course not everyone is going to qualify. And so we go through our assessment of the patient and their exam findings to best match what's the best IOL for them. And sometimes that might be a non-diffractive presbyopia correcting IOL. So that brings me to my first case. This is a 50-year-old hyperopic presbyope who wants to be free of his progressive glasses. He works at the computer quite a bit as an accountant. And we can see that he's a moderate height of about +2, pretty poor uncorrected vision and near. And then when we get our topography, this is what we find. So Dr. Waring, based on all of this information, what surgery, if any, would you recommend?
Dr.
And I'm putting you on the spot here.
Fabulous introduction and a great overview. This is a great case, and our clinic is just full of these people these days. This is probably our largest segment of growth, are the plano or slightly hyperopic presbyopes coming in for refractive surgery solutions. And they've all heard about LASIK, and so they're kind of thinking about laser, and they a lot of times they actually can see relatively well at distance. That's not the case here. But you have to first educate them that LASIK fixes, I like to just kind of say it, LASIK fixes problems you're born with. But you have a separate problem, and that's an aging problem that we need to address as well. And typically we'll address that at the lens, at the internal lens, and we'll show them their pictures on digitally and help show them the differences. But it's rare. I think it's more rare to find perfect topography in any refractive surgery than it is perfectly normal topography. Usually you're going to have some variation. And with a placebo base, which is historically considered gold standard, as you've demonstrated here, you're going to pick up on some of the subtleties of this in a way that can be sometimes more sensitive, but also more confusing. So I like to use tomography as well to get more of a bird's eye view, and that helps cut out some of the noise as well. And it's just sort of a cross-reference for what we're dealing with for the first lens of the two lenses we need to address. So here, you have some irregular astigmatism, and in the left, this is the left eye is where people start thinking about pellucid pattern type patterns of irregular astigmatism with a skewed radial axis. So I'm going to want to look more carefully to understand that in terms of the radial asymmetry, because if you're going to address this astigmatism, you're typically doing it with radial symmetric surgical means. So, and number two, we want to make sure we're not dealing with a progressive disorder. With that said, here's somebody that typically we would shy away from corneal refractive surgery, in which case a lens-based solution could be perfect. We wouldn't really be thinking about a corneal refractive procedure for this person anyway, so that makes this really easy. But the question is, how are you going to address their irregular astigmatism on their cornea? Typically I would use a non-diffractive solution for somebody like this, at least in the left eye. The right eye to be much more comfortable. And we routinely do a mix and match approach where we'll take the healthier eye, take full advantage of that, push the optical system, whether it's with trifocality or not. Frankly, based on what I see in the right eye, I'd be comfortable with that. But the left eye, I'm going to want to understand a little bit more carefully in terms of how I would approach that. Particularly addressing the irregular astigmatism. So I want a tomography, and then I'd kind of understand this pattern a little bit better. I don't think I'm going to go so far as to offer cross-linking or strengthen, but I'd definitely be looking at a lens-based solution, probably conservative left eye, maybe push limits a little bit more on the right eye, and do a blended vision approach. And by the way, non-diffractive on the left is the short answer, and probably also something that is aspherically neutral as well in the left eye.
Okay. Thank you so much, Dr. Waring. You absolutely hit all the points. You hit the nail on the head for all of it in terms of your assessment. We did do a full workup of, this likely pellucid in the left eye with tomography, and we did confirm that it did look like a pellucid marginal degeneration. And based on some old eye records, it did look like it was stable as well, at least in the past 5 years. So I did end up taking a refractive lens approach, as you mentioned, because corneal refractive surgery would be contraindicated in this case. And like you mentioned, also, I did end up taking a mix and match approach. And so I ended up using a non-diffractive extended depth of focus lens in the left eye. I used a toric because he did have a mild amount of, and I was comfortable doing this because he was happy with the quality of vision that he had with his refraction. And so there wasn't too much irregular astigmatism that could not be addressed with a lens. And so I went ahead and implanted that in the left eye. And like you said, the right eye, which in this case would be form frust, was fairly regular. And so I was comfortable placing the PanOptix lens. And he ended up doing great with 20/20 in both eyes, as well as J1 plus at near and intermediate in both eyes. And so I will say that I got lucky in this case because a lot of times when you have ectasia, you can't always hit the target that well. Sometimes you might end up a little bit off target, but here we were lucky in that we did hit what we were aiming for. Dr. Waring, I wanted to ask you, or anyone else on the panel, if you hadn't seen this topography, if this topography were normal and the patient came in with that refraction, would a monovision LASIK be something that you considered first? And how often do you find that your hyperopic presbyopes tolerate monovision?
We, when we educate our this type of patient, we we'll kind of, again, I'll kind of go back to the way we've approached this in the year 2020 and on is LASIK typically fixes problems you're born with. And the refractive lens exchange or custom lens replacement or a lens-based procedure addresses the aging issue that you now have and your distance. You kind of get twice the benefit. So we don't really talk about monovision anymore. In fact, that's one of the distinguishers, how we position refractive lens exchange is that it keeps you balanced. And as a result, our experience is that our patient satisfaction is much higher. And we think that's directly related to maintenance of stereo acuity.
Right, I agree with you.
Progression and so on and so forth, because the bottom line is if you were to do hyperopic LASIK on this patient, you're going to be doing a refractive lens exchange in 5 years anyway.
Yeah, that's a great point, and that's going to sort of alter your outcomes as well, make the calculations less predictable and also affect their ocular surface. So yeah, in the 50-year-old range, I'm with you. I sort of encourage my patients to go down the RLE route.
And limit your lens options. You'd be really hard pressed in this case to be using a diffractive lens with negative asphericity if you were to do hyperopic LASIK in the future.
Right. And in my experience, I also find that hyperopes don't tend to tolerate monovision very well. I do a simple, contact lens trial in clinic, and most of them hate it, and they don't really like the idea of it either, because most of them have great distance vision and they don't like that one eye is suddenly so much blurrier. But the myopes definitely are more tolerant to that in my experience. Okay, thank you so much, Dr. Wang. So I have another case here in which I did a monofocal toric in a patient with more moderate keratoconus, and I ended up not so lucky. I did aim a little bit myopic, and yet I still ended up with a hyperopic surprise. So he was uncorrected distance vision was 20/80, and he was about a +2 residual. And so we have to be mindful of sometimes needing to do enhancements when we're talking about refractive lens-based surgery. So we need to know, what are the best options? So this question is for Dr. Donenfeld, what would you do for this keratoconus patient? Would you tell him to just wear glasses, give him a contact lens? Would you offer an IOL exchange? Would you feel comfortable doing a PRK on this cornea? Would you recommend cross-linking and perhaps a topo-guided PRK? Or do you have another method that you would recommend?
Those are some of the most difficult questions that you've just asked. And I deal with these on a fairly routine basis. And I've always viewed putting a toric IOL into a patient with keratoconus like putting a square peg into a round hole, in that no matter what you do, you're going to get high order aberrations and you're going to have glare and halo. Now, you can get 20/20 vision in some of these cases, but the question is, how functional will it be? So optimally, when I see these patients, I give them some alternatives. Alternative number one would be to fix the topography. And we have the technology to do that now. And I've published a couple of series on these patients. We've treated well over 300 patients like this, where we do cross-linking on younger patients. But on a 71-year-old, I might not even have to do cross-linking, and then do a topographic laser to fix the cornea. And then once the cornea is fixed, you can then go back and put any lens you want to put in, and you'll get a much better result. But that involves a lot of effort and a lot of time, and the patient may not want that. So for this patient who comes in who has a refractive, doesn't want to wear glasses, I would probably lean towards doing an IOL exchange. And I would basically look at the residual sphere that you have here, and your sphere is approximately plus 1.6 or so. Multiply that times 1.5. That tells you how much you have undercorrected the patient. So 1.6 times 1.5 gives you about a 2.5 diopter lens. So just take the lens that you've placed in the eye, add 2.5 diopters to the power of the lens, and you should end up with a very nice refractive result. And then you can rotate the lens. I would use intraoperative aberrometry, but you can go to John Berdahl's website and figure out where to put the lens optimally to get better results as well. So on this patient, since you've already done the surgery, I don't think I would do a PRK. Although I would have considered that as my primary therapy, but at this point, I would probably do an IOL exchange.
Okay, thank you so much for your insight on that. And you make a great point in that now we do have this great technology that we could do a topo-guided PRK, with cross-linking ahead of time to kind of smooth out those abnormalities and those HOAs so that we can, maximize their quality of vision after cataract surgery. But you're right, some patients aren't able or willing to go through all of that. And so my patient was sort of in that boat, and he just wanted to be one and done. And he was happy with the refraction that we had, with this trial frame that we gave him that got him to 20/20 minus. He noticed a big improvement, and he said he would be happy with that. But actually, in this case, I performed a conductive keratoplasty, and I know it's really rare because so few people now use CK. It was abandoned a while ago because it seemed that the results didn't really last. But at least for me, I found sort of a niche of patients to use it in, specifically those with underlying ectasia in which I can't use a surface ablation procedure. And I find that in post-IOL cases, the results stick fairly well. I wonder if some of the regression before was because of the lens just aging over time and then losing some of the effect and some of that hyperopia coming back. But at least in my post-IOL cases, I find that it sticks fairly well. And the practice that I took over, the previous surgeon there, she was a big fan of CK enhancements for post-IOLs. And so I have a long list of patients who I've seen long-term now, and I've seen those CK spots stick for many, many years. And so I'm quite comfortable doing that for a lot of these cases. And it's very easy, it's minimally invasive. And for those who don't know, it's essentially, a thermal technology where you're shrinking and steepening the collagen in one area with high heat, and thereby, steepening and treating hyperopia. And so I will use it on hyperopic patients as well as those with any mixed astigmatism. And so for this patient who had a residual of +2, I did a 2-ring CK, and he ended up being 20/20 and essentially plano. And so he was very happy. And so it's kind of a lost art because I feel like I'm the only one who uses it these days, but I do find that it can be helpful in some situations. Again, because it's minimally invasive, I feel like I am not harming the ocular surface. I'm not severing any nerves, which can be concerned about, the tear film in a lot of these older patients. And I also know that I'm not going to be inducing any ectasia because I'm not cutting or ablating any tissue. So, yes.
I have a question to ask, and I think it's also come from the audience. Somebody suggests that they tried out light adjustable lenses in these ectasia type of patients, and I just wanted the panel's thoughts, Dangy, yourself as well. What are your thoughts? Have you used it in ectasia patients? They say that they've got great results in patients with ectasia. So any thoughts on that perspective?
It's a very good suggestion. Yeah. So go, Priya.
Oh, no, I was going to say, it's obviously something that, any patient population where you have a high risk of a refractive miss, that can be a great technology. I think the ultimate difficulty in an ectatic patient is that they're not stable most of the time, right? So even if you get them to be where you want them today, a year, 2 years from now, there'll likely be a shift. And, if you go back one slide, Dagny,
Sure.
One thing that I always look at when I, look at, okay, toric, non-toric, but there's a 3 diopter difference, in the cornea. I don't know which eye this is, so nasal or temporal, but in the horizontal meridian. So, it's 50.8 and 47.6, I believe. And so to me, that great of a difference is, to me, it says, hey, I'm likely not going to be where I want to be. And you mentioned you aimed more myopic. And I think that that's something that people don't often take into consideration. The steeper the cornea, the more hyperopic you're going to end up. And there are a couple of papers in the literature that actually publish a correction factor, for the degree of steepness and how much myopia you should aim for. So that's worth checking out.
Dr. Gupta, do you have a specific formula that you like to use for keratoconus eyes, or do you use some sort of technology to help you kind of hit the target?
You know, I do use intraoperative aberrometry, but in general, like when I am, if it's a keratoconic eye with a very steep cornea, I will kind of adjust to aiming to, you know, a -2 or a -3, sometimes even -4, because it really, I mean, it is a wild card. It's a floppy cornea, but also you have to think about what's happening in their other eye. Sometimes these patients, often I think of this in my post-PK patients, you know, where their cornea doesn't behave as regularly. They don't have a transplant in the other eye, don't have a cataract. And so anisometropia can be a big deal. And I also, kind of in the beginning of your lecture, you mentioned, you know, yes, in the refractive population, you're asking what patient expectations are, et cetera. But even in these compromised eyes, many of these patients have been extremely myopic for many years, or have had extremely high levels of astigmatism, which, you know, spherical equivalent is myopic. And so for them, if they're all of a sudden hyperopic, but they were used to being, you know, in focus here, granted, it's not a great focus, they have a lot of astigmatism, but it's their natural pattern. And I think that's really important to assess in these patients with irregular corneas or post-PK, et cetera.
Perfect. Thank you so much for sharing your insight on that. We will actually come to our next case. And I think we've all had one of these patients walk into our clinic, 53-year-old male, plano presbyope, and all he wants is to be free of readers. And again, we do the whole workup, and this is his topography. So Dr. Gupta, how would you proceed in this patient?
I love that you're finding all these like weird corneas.
these are real eyes that have walked into my clinic.
So here, you know, before you showed me that topography, I was thinking, okay, just wait a year. There'll be an eye drop. It'll be fine. And maybe we're still going to tell him that after I see this topography. But, you know, I get topography and tomography in all of my patients that come for refractive eval. But, you know, there's so many things when I see that, you know, I think, okay, wait, did you actually have a surgery in the past that I didn't know about? You know, lots of patients have no clue what happened to their eyes. You know, patients will say, oh yeah, I had a procedure. I'm pretty sure it was this, and, you know, something else. So obviously you got to pair your clinical exam, but, you know, so I think of ectasia, I think of keratoconus, but also I think of, you know, lumps and bumps in the cornea, you know, Salzmann's nodules, ABMD that's sort of heaped up. And then, of course, you know, there's a lot of missing data in that topography. So I think of ocular surface disease, all sorts of lid issues. You know, I've seen topographies like this from patients that have done orthokeratology for, you know, they've worn contacts, sleep in them 24/7. So I mean, broad differential here, but those are the things that I think, you know, when you're getting in that refractive mindset, I do, before I walk into the room, I always look at the topography or the tomography, because it gives me, you know, my index of suspicion for, okay, how much am I gonna have to dig on this patient to figure out what's going on here?
Yes, and thank you for that amazing celebrity panelist quality differential diagnosis. I think you hit everything. And the orb scan itself, yeah, it's combined of placido disc technology, and that's going to be a lot more sensitive to ocular surface issues. You're going to have more dropout on the topography, whereas the tomography, for example, the pentacam may be less affected by that. So the easiest thing that you can do in these sorts of situations is, you know, to lubricate the patient probably and rescan them at a different time to see if that is real. And so that is what I did. And after only 2 weeks of aggressive lubrication, this is his real topography, which, you know, that keratoconus suspect kind of looking cornea went away, and he just has a normal amount of regular astigmatism. So it's amazing how even just regular dry eye can look so different on topography when the tear film is not well controlled or maintained. And so Dr. Gupta, how can you explain or describe what your typical regimen is for patients with dry eye?
Yeah, so I mean, I'm assuming that patient had, you know, actual corneal staining and a poor tear breakup time. So I kind of pieced together what's going on, but the first thing I reached for is a topical steroid. Topical steroids work very quickly. A refractive population is not really a to do this long drawn out, therapy. And so that to me, artificial tears, ointment or gel at nighttime, and a topical steroid, and then let's reassess things in 2 weeks. Now, in my clinic, I'm often seeing these patients after they've had all their tests. So if they have a normal looking cornea after I see them, I'm very impressed. And I think that there's no way they're going to have any dry eye. But, sometimes the things we do to the patients as they go through their testing, maybe there was a particularly, rough IOP measurement or something. So, those are all things that can go and be temporary problems with the cornea. But if after a couple weeks of steroid and lubricants, if they come back and they still look irregular, they still have corneal staining to me is sort of a hard stop. We really do need to get rid of that before I consider any laser vision correction. And certainly in my refractive cataract population, same criteria apply. And so from there, that's somebody that I might add a chronic topical immunomodulator like a Xiidra, Restasis, Cequa. Those are all excellent medications. And really, of all the things I mentioned, probably the most important thing is just an honest conversation with the patient, because these are patients so motivated, that glasses is a true disease to them. A refractive error is true disease. And so, they want to see better, but they don't understand the impact of what's going on, that they have refractive error plus ocular surface disease, and that the ways in which we treat their refractive error are highly likely to exacerbate that condition. And, unfortunately, there's been some, in the press and in the mainstream, I think, patients are more aware of dry eye. I certainly get a lot of questions about, well, how likely am I to get dry eye? And so I just think that it's 2021. We can't really be sort of saying like, oh, you'll be fine, because our patients are not going to accept that as a side effect.
Absolutely. And like you said, some patients, even after all your aggressive treatment and the steroids and even, the longer term kind of dry eye treatments, their repeat, scans still look like this. And so what if that same patient, we did everything for him and he's very motivated. He tells you he really wants to be free of his readers. He works as a manual laborer, and the glasses, he can't work with them. They fall off his face. Dr. Waring, what would you say to a patient like this? Is surgery even an option?
It's that what we would want to do is really kind of throw the kitchen sink at him. If we are convinced that his topography is going to interfere with his measurements for whatever intervention we're looking at, and B, his performance afterwards, and C, their healing process as well. And so, this cornea is labile at best. And, this is somebody where I'm going to want to really understand and see serial topographies. This is where we're going to talk about, additional investment. If he's willing to invest in vision correction, which he sounds like he's highly motivated, then we're going to just help him understand the importance of a healthy ocular surface for all the reasons we just mentioned. And we published a paper a number of years ago that showed the objective impact on your vision with dry eye. So it's not just your measurements, as has been also published, but it's also how do you perform. So we describe this as vision performance. So we don't want to try to go through these measures to fix him, but that he's having poor performance, nobody's happy. So we usually make a strong recommendation on thermal pulsation preoperatively, plugs, in addition to the measurements that or the measures that Priya so eloquently described, and really kind of get them. We don't expect them to go a few years through their therapy, but we want to get them a few months through therapy until things have really stabilized. The other thing too is we want to understand, is there a lot of times these patients with long-term surface disease have underlying EBMD that is what we kind of call form-fruste EBMD. It's you're not going to see the traditional maps under the microscope. Sometimes you can see some negative staining with lids averted for a longer period of time. That can be really useful. But ultimately, the epithelium often just masks CBMD, and you'll pick up on these patients definitely in long-term contact lens use wearers. We think that there's a correlation if you do surface ablation and you unmask these maps that you couldn't see under the microscope. So that's always a possibility too. You have to be thinking about that. The bottom line is we know that these patients are refractive patients because ultimately you're going to end up doing cataract in this patient in the next 20 years, which is going to be the most common refractive procedure. So you're going to be able to fix this person. It's just a matter of getting them as far as they can get to get the best result, then also letting them know that that's a contract long-term to maintain. Like if they're trying to lose 50 pounds, you got to keep working on it the rest of your life. And then also making sure you're documenting some of these underlying issues and some of the unknowns as well. But typically with plano presbyopes, we're typically doing lens-based procedures these days for the reasons that we mentioned earlier. We also believe that is more forgiving on the corneal surface as well. But we want to make sure that their corneal surface is as healthy as possible, like we discussed.
Mm-hmm. And Dr. Waring, if this patient did ultimately develop cataracts and they needed surgery, and he still really wants to be free of his readers, would you be comfortable placing a trifocal, or what IOL technology would you be looking towards using?
Well, I'm really not crazy about any of the scans for anything yet. So I'm going to want to see this stuff stabilize first. I'm going to want to understand better why are they looking like this. I mean, I think that's kind of the key. What's going on? But it's pretty rare in the absence of pathology that we can't get corneas somewhat normalized to offer an advanced technology lens to help them. But I don't really consider these scans there yet.
Right. So
I'm going to work on.
Absolutely. We worked with this patient. We threw the kitchen sink at him, as you would say, for actually several months. And we put them on a low dose steroid taper, but I also started lifitegrast or cyclosporin, as well as, obviously frequent tears, ointment at night, and also an Ilux treatment. And eventually the topographies did stabilize to the point where I felt I could comfortably proceed with surgery. I still was not comfortable placing a trifocal lens though, because I feel like those ocular surface issues never really truly go away. And so I ended up actually doing the non-diffractive extended depth of focus lens. And he ended up being J2, and he was happy with that because it's still a huge improvement from J16. And so as long as you counsel these patients that you still need readers, I think be very happy.
Also fudge near target a little bit on one eye as well. And I think that's an acceptable solution, particularly as things normalized a little bit.
Absolutely. So here we have a 75-year-old woman with cataracts. And she really just wants to improve her distance vision. She feels like her near vision, which is J2, probably because of that astigmatism in the right eye, is fairly good. And she doesn't wear any glasses at all, and she does not want to. And you do, your screening topography, and then she tells you, oh yeah, doc, I did have LASIK surgery over 30 years ago. And so Dr. Donenfeld, how do you handle post-refractive patients seeking spectacle independence?
Well, I see a number of those. We've been doing LASIK for a long time. So these patients are all coming back home to me now, 20 years later, asking for this. And one of the things that I've learned is that patients who have had previous LASIK are the ones who are most interested in a presbyopic solution because they really value the fact that they didn't wear glasses for so many years and they want to go. So this is a hyperopic LASIK. You have to realize that this patient has pretty steep corneas. They've become more prolate, which is the opposite of most patients who have LASIK, so that they have negative spherical aberration, which gives them a little more depth of field. A patient like this, number one, you need to get really good IOL calculations, which are sometimes difficult. I really like to use the Barrett formula here. I find it to be by far the most helpful for post-hyperopic LASIK. I also like to use intraoperative aberrometry on these patients as well, because it gives me just that extra belt and suspenders in getting the right IOL. And then when you go to fix this patient, and this patient is clearly not a candidate for a PanOptix lens. They have almost every strike against them. They have a decentered ablation. They have a hyperopic ablation pattern. So you can put it in, but your risk of glare and halo here is extremely high. I think that the new lenses that you discussed before, Dr. Zhu, the Vivity, and I would also add the iHance to that as well, which is another brand new lens, which gives you about a quarter diopter less than the Vivity. Both these lenses are wonderful for the patient who has the less than ideal cornea, but still wants to have a little bit extra near vision as well. And for me, this is a patient who right now essentially has monovision. The spherical equivalent in the right eye is about a -0.5, and the left eye is about a -0.5 as well. I would probably look for the dominant eye and aim for distance. And what I do, because the chance of getting the right correction is pretty low because of the hyperopic laser, I aim actually for the first plus in the dominant eye, because the half a diopter you get with the iHance or the 3/4 of the diopter you get with the Vivity will allow you to still see 20/20 at distance. And then the non-dominant eye, I might add a -0.5 to the treatment. And then with the Vivity, that would give you essentially a half a diopter from the monovision and a 0.75 from the lens. And you'd have a diopter and a quarter of reading in the non-dominant eye. And these patients, in my experience, have done extremely well with this combination of mini monovision with a refractive, extended depth of focus lens, again, like Vivity, or I would add iHance as well into that conversation.
Yes, thank you for mentioning iHance as well. And I know that you mentioned that it sounds like you don't use diffractive technology or trifocals in hyperopic patients in general. I know some people, some surgeons might still do it if the HOAs or the higher order aberrations were not too high. So my question for you is, do you have a specific higher order aberration cutoff that you use to help you decide when you can use a presbyopia correcting IOL?
Well, it depends upon which aberrations they have. You expect this person to have spherical aberration. The question really is, how much coma do they have? Some people use 0.4, some people use 0.5. You want to also look at the angle kappa, or George will give you a better definition than I will on that, and look at the centration here. I get almost. Go ahead.
Oh, so this patient looks like it was a 0.266 in the right eye and a 0.3 in the left eye. Does that mean anything to you?
That's in the normal acceptable range, but looking at the high order aberrations, doesn't give you the whole story. I'm looking at a ablation that's clearly decentered, which is the classic hyperopic ablation. They're almost always a little decentered. And yes, you can put in a PanOptix lens in a patient like this, and you can get tremendous reading, but I think you're going to sacrifice a lot of distance vision on a patient like this, and they're going to have a lot of glare and halo at night. And while the PanOptix is a wonderful lens, these are the cases that I try to avoid using a trifocal lens on.
So
now tell me, you did it, I would imagine. No?
No, I agreed with you,
Okay.
Dr. Donenfeld. I implanted the Vivity in both eyes with the micro mono approach, almost exactly as you described. So the patient was dominant in the left eye, non-dominant in the right. So I aimed a -0.5 using the Barrett post-LASIK formula. And I aimed for plano in the left. And she was very lucky to end up right on target. 20/20 OU at distance, J1 at intermediate, and J2 at near. And she was very happy with that. So exactly as you had described. For the same reasons that you described, I would also avoid a trifocal in this patient. And then here we have a 59-year-old man with a history of RK to improve his distance vision. And actually his left eye, he feels is fine, but his right eye is the one that bothers him. He's quite myopic in that eye. And but he's J1 plus in that eye, so he takes off his glasses to read. So he likes his J1 plus. He would like to keep it, but he would love to improve the distance in his right eye. And so, Dr. Gupta, how would you proceed in this RK patient?
Well, I think that, first of all, you have to see how irregular those incisions are on topography. He's 20/40 with almost no refraction in the left eye. So, that there's definitely some irregular astigmatism that's likely causing some change in his vision. Maybe he has a little bit of cataract, but he's only 59. Those patients often don't have a ton of lenticular changes. But if he was okay with the left eye, I'd focus on the right eye here. This is a patient that I would be concerned with. He's saying that he wants to improve his distance vision, but he also probably does not want to lose that near vision that he has. It's remarkable how these patients sort of adapt over time and just forget, what their natural visual system is doing. So I'm not a big fan of doing, anything other than monofocals in these patients. That said, with what I would call regularly irregular astigmatism, I have used the Vivity implant in these patients. But remember, your target is a little tricky because these patients are one that often will become a little more hyperopic over time as their cornea continues to gape. And so what you give them, if they have a large number of incisions, and this looks like 8 cut RK, which is, not often too terrible. There's certainly patients out there with 16, 32 and beyond, which, it becomes a very unstable cornea. So to me, if I gave you broad brushstrokes, first assess the stability of the cornea. If it's unstable, don't proceed with cataract surgery until the cornea is stable. And then if it is stable, I like to aim for a slightly myopic target so that they get the benefit, as he certainly would appreciate retention of some of that near, but more importantly, if that truly that 20/40 vision is from a myopic shift from his cataract, he'll be happy with the clarity as well.
Absolutely. So in these types of patients, we have to avoid sort of that diffractive technology. So really we have to rely on a non-diffractive technology with perhaps leaving them slightly myopic to preserve that near that he likes. And so I did a trial frame, leaving him kind of mini mono to see how he would feel about a -1 in that eye. And he was happy. He felt like the distance was much improved and he still got J1. So that's what I targeted with the Vivity lens. And you could use any, non-diffractive lens of your choice. And I aimed for a -1 using the post-RK calculator. Again, very lucky to hit the target. And he ended up being 20/30 in that eye and J1, which he was happy with that near. Okay.
In these cases, I think there's one more suggestion which I think comes through is, using the IC8 or the pinhole IOL, because I think you kind of remove all the abrasions that you're dealing with, which are, constantly there. We don't have the IC8 in India, but we started doing the pinhole pupilloplasty, which is basically post-operatively, these patients come back, and that's when you really need to go back and do something else about it. And the only option over here is right now pinhole pupilloplasty, but IC8 is a great option in the US. It's already available. So I'm guessing that's another good chunk in your armamentarium which you have.
That's a great point. Thank you, Ashwin. How are we doing on time? I can sort of skip through the next case.
We are actually over time by 2 minutes right now.
Okay, so I will just skip this case here.
Right.
And just kind of get to a summary here of how we can really optimize our outcomes when we're talking about refractive surgery by using the femtosecond laser. I like to use it because it centers the capsulotomy on the visual axis and actually makes these really cool toric capsulotomy marks, which helps me to orient my lens. And of course, the 8Ks are a lot more precise for correcting astigmatism as low as half a diopter. And I know Dr. Gupta has, developed this amazing eye calculator with Dr. Wertz. I was just wondering if she could talk about it really quick, and then we can wrap up from there.
Perfect.
Sure, I can give you the 20-second highlight.
Yeah.
So we basically wanted to figure out, does treating low levels of astigmatism matter? And the short answer is yes. People see better if you treat their astigmatism, even if it's a half diopter or under a diopter, is what we studied in the paper that was published last year. And there has not been a femtosecond validated laser art calculator that's freely available. And so we put together this website, lricalc.com. I hope everyone goes to it and uses it. We have about 1,200 calculations that are being done a week. So we've gotten quite a bit of adoption. And we boiled things down to have just 3 to 4 inputs, depending on if you're putting an ID number. So it's simple to use and it's freely available. And take home is treat astigmatism.
Thank you so much for that. And I totally agree with you. And, you know, sometimes even with everything, you know, doing perfect surgery with our AKs, femtosecond laser, sometimes we just still have those unhappy patients, even if they're 20/20 J1 plus. So we have to make sure that, you know, we're always listening to the patient, acknowledging their issues and walking with them towards a solution. And so in summary, presbyopia correcting IOLs have come a long way. It's really up to the surgeon to match the best IOL to every patient based on their needs and their exam findings. And topography is absolutely critical in all of these cases. So I just want to thank everybody for your time. That's my little boy. He's 8 months now, Atlas, and he's sitting up quite well, still trying to crawl. He's scooting backwards. But yeah, please email me or contact me if you have any more questions. Thank you again.
Great job. Thank you so much, everybody.
Yeah, well done.
Thank you so much, everyone.
Dagny, thank you so much. This was a fantastic presentation. And I think the celebrity panels, you guys just rock. Honestly, I learned so much on these events. And I've been learning so much from all you guys, each of you. Closing in today, I think I'd like to thank everybody who's been involved in today's episode. And, you know, the talk was fantastic. The discussion was even more beautiful. We're definitely going to have this episode on our website in the next 48 hours, a little bit of, you know, the post editing stuff, and then 48 hours it'll be up on our website. So all the viewers who want to miss something in the event can always go back and watch it. Please follow us on the social media handles. risingeyestars.com is the website, and Twitter, Instagram is Rising Eye Stars, Facebook and YouTube is Rising Stars in Ophthalmology. We will definitely see you in the next and the last episode next month. I'm going to have to definitely sign off now because my celebrity panelists are already rolling their eyes on me.
No, we're getting ready for bed. It's like almost 10:30.
It's really late over there. Yeah.
Yes, man.
I'm going to eat dinner.
There you go.
Bye.
Great job to everyone.
Thank you.
Thank you, George. Thank you, Priya. Thank you, Dagny.
Thank you. Thank you, Ashwin.